BiPAP or standard face mask oxygen. So kind of talking about acute hypoxemic respiratory failure, we still don't have a lot of data on what the best ventilator-sparing treatment is for this. We know about several modalities that we use every day, including face mask oxygen, be it through a non-rebreather mask, venti mask, or what have you, positive pressure ventilation, or heated high-flow oxygen. But there's still no real consensus about what the best treatment is for acute hypoxemic respiratory failure. We know about the benefits of bilevel positive airway pressure, mostly in hypercapnic respiratory failure with COPD and CHF, and then also some data about neutropenic pneumonia. When we look at acute exacerbations of COPD, the most cited trial is from back in 1995 by Brochard and colleagues talking about non-invasive ventilation. What they did was they took some ICU patients, they found the sickest ones out of that group, and they randomized 85 ICU patients to standard therapy versus BiPAP, and looked at the need for endotracheal intubation. The BiPAP group, or actually the CPAP group plus or minus BiPAP, was associated with shorter hospital stays. They had decreased in hospital complications, and they had a lower mortality rate, which was pretty impressive, 9% versus 29%. And then looking at CHF, again, the most cited article is this meta-analysis that came out in 2005 with both CPAP and BiPAP decreasing the need for intubation. They found, again, a 45% decrease in mortality for acute pulmonary edema. Looking at non-invasive ventilation, what do we know about non-invasive and acute hypoxic respiratory failure? There's a high rate of treatment failure, depending on the PF ratio, up to about 50%, and not too much different from 60% with standard oxygen therapy. There is difficulty with secretion clearance, which is a big issue, and an exceedingly high mortality also. It's not that comfortable, trust me. On the other hand, we have the high-flow oxygen device. There are two devices on the market right now. What you're looking at is the OptiFlow device. That's what we have here. There's also the Vapotherm device, and these are pretty new compared to the other two. So high-flow devices deliver heated, humidified oxygen mixed into a driving gas at a really high flow rate, on the order of about 50 liters per minute. Both the FiO2 and the flow can be titrated to the patient's needs. There is a small amount of PEEP that's caused by the intense flow of oxygen here, and it's known to wash out carbon dioxide out of the dead space. So both of these mechanisms are thought to decrease the work of breathing. Again, humidification of the driving gas is important too. For tolerance, blowing a lot of air into someone's nose at this rate would dry them out pretty bad. So there's a lot of humidification that goes along with this. And it's thought to help out with mucociliary clearance too. And again, looks more comfortable. She's obviously happier than I was in that last picture. The benefits of high flow have been documented across a variety of clinical scenarios. A lot of mostly industry studies showing benefits. This is in cardiac surgery patients. They found improved end expiratory lung volumes and decreased respiratory rates post-cardiac surgery. As a first line of treatment for respiratory distress, pre-intubation in the emergency department. A study in the bronch suite about improved oxygenation and better or quicker recovery during bronchoscopy versus venti mask. Improved outcomes post-extubation, mostly in the PACU. And then there's long-term use studies also in COPD, pulmonary fibrosis, and bronchiectasis. And then we also know about neonates with respiratory distress syndrome. However, acute hypoxemic respiratory failure remains not as well studied in full code people. There was a do not intubate sort of study before this. So this study kind of looks at, is this a better alternative to mechanical ventilation, or can we at least spare some people from the ventilator? And if we did spare people from the ventilator, will we have fewer events and decreased mortality? Hence the Florali trial. So this was presented at ATS back in May of 2015 and published in June 2015 on New England Journal of Medicine. Looking at the PICO question for these people, study design-wise, the patients are going to be people with acute hypoxemic respiratory failure without evidence of hypercapnia. The intervention is that we're to give oxygen in one of three ways, either with standard face mask oxygen or through a BiPAP machine or through the Highflow device. And the primary outcome that we're going to look at is intubation, but we're also going to look at secondary outcomes, including ventilator-free days, mortality, and complications. A brief word on the study design. It's a multi-center randomized controlled prospective trial. This is done across 23 ICUs in France and Belgium, was approved by their respective review boards in each country. This is done from February of 2011 through April of 2013. And the equipment, including the OptiFlow device and the BiPAP mask, are all provided by Fisher & Paykel, makers of OptiFlow. Inclusion criteria. Adults basically with acute hypoxemic respiratory failure, so 18 or older, a respiratory rate greater than 25 at presentation, a PF ratio less than 300 on at least 10 liters of oxygen for at least 10 minutes or more, a PaCO2 less than 45, and no history of chronic respiratory failure. Exclusion criteria are any sort of hypercapnia greater than 45, an acute exacerbation of asthma, COPD, CHF with pulmonary edema. Severe neutropenia, although some lesser immunocompromised people were invited into the study. Anyone who's hemodynamically unstable on pressors is not invited. An urgent need for intubation, a do not intubate order, or a lack of informed consent. The patients that were included were randomized in 1-to-1-to-1 blocks to receive face mask oxygen, non-invasive ventilation, or Highflow. And they were also equal amongst hospitals with a history of CHF, with or without a history of CHF. It was pretty quick. Within 3 hours of confirmation of the inclusion criteria, the patients were randomized to one of the 3 interventions to start right away. So looking at the groups of therapy, the first is going to be the standard oxygen group. These people were given oxygen through a non-rebreather mask with a flow rate of at least 10 liters or more, and that was titrated to maintain a SAT of 92% or better. The patients get a choice to either recover and transition a nasal cannula or get intubated. The high-flow oxygen group uses the OptiFlow device with large bore nasal cannula, like this lady here reading. The initial settings were going to be an FiO2 of 100% at a flow rate of 50 liters per minute. That's again titrated for a SAT greater than 92. And again, the device must be worn for at least 2 calendar days, and they could either recover and transition down to nasal cannula after the 2 calendar days or get intubated. The BiPAP group, they get standard face mask BiPAP. It was connected to a ventilator just like we do here. They start with an initial PEEP of 2 to 10. Pressure support was adjusted to maintain a 7 to 10 cc kilogram per ideal body weight tidal volume. And the FiO2 was adjusted to maintain a SAT 92 also. So the rules for the BiPAP group are that they had to wear the mask for at least 8 hours a day over the first 2 calendar days. When they wore it for 8 hours a day, it had to be done in at least a block of a 1-hour session. They could take it off for comfort or to eat. And between those sessions, all of those patients were given Highflow as an OptiFlow therapy. And they had to go back on the BiPAP if they had a high work of breathing with a respiratory rate of 25 or greater, a SAT less than 92. And then who gets intubated? It's generally kind of a personal decision that varies among practitioners. They tried to make some standardized criteria for intubation, including hemodynamic instability, mental status changes with deterioration, worsening respiratory failure, which was defined by a respiratory rate greater than 40, no improvement in accessory muscle use, problems with copious secretions, acidosis, or hypoxia despite optimal oxygen delivery. Looking at the primary outcome, it's going to be the proportion of patients that get intubated by day 28 of their ICU stay. It's important to note here that prior to intubation, both the Highflow and the standard oxygen groups could undergo a trial of BiPAP at the discretion of the physician. So things do get crossed over here a little bit later in the study. Other outcomes that we're going to look at are mortality in the ICU, mortality by 90 days, the number of vent-free days for the duration of ICU stay are 28 days, complications including septic shock, nosocomial pneumonia, arrhythmia, and cardiac arrest. And then dyspnea and comfort. Dyspnea was rated on a 5-point chart, with kind of the middle point being no change in dyspnea, 2 points on the left being negative change, or 2 points on the right being somewhat change or marked improvement. And then comfort was based on a 10-point sad face, smiley face sort of graph here, written in French. Looking at the analysis of the data here, previous studies of non-invasive ventilation and hypoxic respiratory failure due to pneumonia were used to help power the study. Those studies found about a 60% intubation rate with standard oxygen and 50% with non-invasive ventilation. So they found they would need 300 patients to power the study adequately to find a significant difference in the primary outcome. It was done an intent to treat analysis, although not too many people dropped out of the study. And they did analyze one subgroup of patients with moderate to severe respiratory failure, defined by a PF ratio less than 200. Looking at the results, this is done over a 2-year period. 2,500 patients were screened at the 23 participating sites. 525 were found to be eligible. 313 were randomized into the study. 3 patients withdrew consent. 2 of them were in the standard oxygen group, and 1 was in the BiPAP group. None were in the OptiFlow group. So a total of 310 patients were analyzed. And the way those were divided up, there were 94 patients in standard oxygen. The most patients were in the BiPAP group, and 106 patients were in Highflow. The baseline characteristics of these people were pretty similar in terms of their age, gender distribution, SAP scores, and smoking status. The main cause of hypoxemia in this case is by far and away pneumonia. Community acquired, a minority of those were HCAP, and then extrapulmonary sepsis, aspiration or drowning, and neutropenic pneumonia. Most of the patients, but not all, had bilateral infiltrates. And most of the patients, but not all, had a PF ratio that was pretty low into that subgroup, less than 200. So 77% are less than 200. A breakdown of the people. These are the reasons for hypoxemia. You can see that most of it is community-acquired pneumonia. Remember that any sort of chronic respiratory failure was an exclusion criteria to get into the study. So a lot of these people are coming in outpatient. So community-acquired in green is going to be HCAP. This is immunosuppression, but not terribly neutropenic pneumonia and aspiration. Pink and purple here are non-pneumonia causes, and that's kind of a minority. So 84% of people in this study had some sort of pneumonia as the cause of their respiratory failure. Looking at the treatment, so standard oxygen patients received a mean flow rate of 13 liters per minute. High flow patients received a mean flow rate of 48 liters and an FiO2 mean of about 80%. BiPAP patients got a mean PEEP of about 5 and a pressure support of 8. Interestingly, the mean was 8 hours a day. Now, all patients should have worn this for 8 hours a day. The interquartile range was 4 to 12 hours on day 1, and then a mean of 8 hours on day 2 with 4 to 13 as the interquartile range for those patients. So it seems like not a lot of these patients could tolerate BiPAP as much. There was a lot of crossover here, but despite that, there's really no significant difference in the timing of intubation across the 3 groups, and even in the subgroup of the worst hypoxemia. Reasons for intubation were similar across the board. 26 patients in standard oxygen got rescue therapy. 73% of those people got intubated from BiPAP. And then 14 patients got rescue therapy with BiPAP from the high flow group, and 64% of them got intubated. Looking at the primary endpoint, this is intubation at 28 days. What you can see is that there's really no significant difference between the 3 groups. Standard oxygen patients, 44 out of 94 patients were intubated, that's 46%. Non-invasive patients, 55 out of 110 patients got intubated, that's 50%. High flow still had the least, but a non-statistically significant difference of 37.7%. It's just the Kaplan-Meier plot from the article showing the primary outcome here. If you take the subgroup out of the equation here, now we're looking at patients with a PF ratio less than 200. There is a significant difference in intubation rates here. 52% in the standard oxygen group, 58% in the non-invasive group, and in the high flow group, 29 out of 83 patients for 35%. This significant difference was noted even after adjusting for bilateral infiltrate, CHF, and respiratory rate. When you put the two together, you can see in light blue this is going to be all comers, and then in green is going to be the people with the PF ratios less than 200. I think it's interesting that even the sicker patients, a smaller proportion in the high flow group only, get intubated. And again, the Kaplan-Meier plot looks a little bit different when you pull out the people with the worst PF ratios here. High flow oxygen is significantly associated with less intubation at day 28. Looking at secondary outcomes, the first mortality indicator is going to be all-cause mortality in the unit. There is a little bit of a significant difference here in terms of mortality with the high flow group. 12.2% of them died in the unit versus standard oxygen 23.4% and non-invasive 28.2%. And then 90-day mortality is also here. Not too much change between the numbers after the first 28 days, but again, you can see that with a p-value of 0.02 that this mortality difference does carry over at 90 days for high flow. Looking at other secondary outcomes, the people that do get intubated, looking at mortality on the vent, there really was no difference in mortality for anyone who gets intubated from any of these three groups. Standard oxygen therapy, 20 out of 44 intubated patients, 45% died. Non-invasive, 49%. And high flow oxygen, still less but not statistically significant at 30%. Looking at ventilator-free days, the high flow group had significantly more ventilator-free days. Kind of looking at the difference here. Interestingly, the BiPAP has the least. If you look at the subgroup analysis, the people with moderate to severe hypoxemia, not a lot of changes between ventilator-free days. And like we looked at the high flow oxygen group, even fewer of those got intubated, percent-wise. Looking at complications, there are really no difference in complications. Serious ones, including septic shock, nosocomial pneumonia, arrhythmia, or cardiac arrest. If you look at septic shock, it is lower in the high flow group, 17.9% compared to 27 and 30% in the oxygen and BiPAP groups. This approaches statistical significance. It makes you wonder a little bit about hygiene issues on the vent and mucociliary clearance with the OptiFlow. But then looking a little bit further, there really was no difference in nosocomial pneumonia. So I wonder what the mechanism behind that is. Looking at dyspnea and comfort, patient discomfort was not really different at inclusion. Everyone was well matched in terms of their dyspnea and comfort scores. However, at 1 hour, there's a significant improvement in comfort in the high flow oxygen group. Dyspnea grading improved more with high flow than with non-invasive. Significantly at 1 hour, respiratory rate was a little bit lower in the high flow, but not with the non-invasive. At 6 hours, they all kind of equaled out anyway. So that's the data. Any questions, any sort of discussion points that you guys have? Good, I brought topics. Study strengths. I think the strengths of this trial is that it was multi-center across 2 different countries. 23 different centers participated. The patients were randomized quite quickly and started on the therapy quickly within 3 hours. It was a sealed randomization, so the patients had very similar baseline characteristics, and the investigators were unaware of the results until all the data were locked in. The patients were stratified by cardiac disease, and there were sound criteria for intubation. Limitations of the study, obviously this is going to be impossible to blind. At the end of the day, the study was underpowered to detect the significant differences in intubation rate. So it's essentially a negative trial, although we did learn a lot about mortality from the study. A significant majority of the patients, like we talked about, greater than 80% with pneumonia, so it might be difficult to generalize the study across all causes of hypoxemia. The patients on BiPAP really did spend a significant amount of time off therapy and on the high-flow therapy, but were still associated with worse outcomes. And then the crossover to rescue therapy prior to intubation probably confuses things a little bit, but it's also more representative of what we do in practice. Interestingly, the study started in 2011. There were different criteria for the diagnosis of ARDS at that time, so it's called the FLORALI trial, and the ALI stands for acute lung injury. But 20% of these patients had only unilateral infiltrates. And now we have different sort of definitions for that. And then I wonder if it was practical to exclude all patients with chronic respiratory failure, given the industry studies that we talked about and how those patients are known to benefit from high flow also. And with profound immunosuppression, if one of the advantages to this device is better mucociliary clearance and better hygiene than a BiPAP machine, I wonder if other patients that were more immunosuppressed should have been invited to the study too. So the questions that we're left with here is that the BiPAP patients, many met criteria for ARDS. They received a mean tidal volume of 9 cc's per kilogram of ideal body weight, and they had the highest intubation and mortality rates. It makes us wonder if we're hurting our patients in acute hypoxemic respiratory failure with the BiPAP device to begin with. And at this point, do we have enough information to switch our first lines of therapy from either BiPAP or face mask oxygen to high flow? Any comments? Dr. Oddish.
I think one of the things that I worry about with this, because of my patient population, is because of the unrecognized number of patients who have PFOs and shunting, that what I see when this is used in my patients in the unit is that they actually get more hypoxemic because they shunt more from the effects of PEEP, and their requirements are escalated, and they really look sicker than they are, where we can turn it down and put them sometimes on just a Veni mask. And so I wonder if there was any discussion, or if you had any thoughts about whether those patients should be excluded. Right.
So there wasn't any sort of exclusionary criteria other than the cardiac disease, which really wasn't well defined even. Interestingly, in healthy volunteers looking at how much PEEP they really get, with an open mouth on the maximum flow rate of OptiFlow, you can get about 3 centimeters of water at PEEP. Closed mouth, you can go up to about 7.5 or 8, so it can be significant. Sir?
So with such a study, I think they did well by excluding all patients with chronic respiratory failure or other disease, because it's such an intervention that I'm really curious whether or not we're delaying the intubation. And we know from previous literature that putting acute hypoxic respiratory failure on non-invasive, an NIPDV, is going to increase the mortality if it's going to delay intubation. What I see from your results is that there are subgroups of statistically significant improvement on high flow compared to the non-invasive and regular ventimask, right? But am I wrong if I say that, depending on this study and on previous literature, looks like if your acute hypoxic respiratory failure patient is secondary to pneumonia in particular, and I wish that this study was only done on pneumonia. I'm not sure if this is right, but I think if they just did it just for pneumonia in a healthy patient with no other issue, this might have helped us more in clinical practice. Am I right if I say that putting patient on a ventimask or on a simple mode of oxygenation till they deteriorate and then intubate straight ahead is safer than using any of these two modalities, depending on previous literature and depending on your...
In hematologic malignancies, the data supports using non-invasive ventilation over intubation. That actually, the patients who were intubated, they had a higher mortality. So I don't know that we can make sort of a blanket. I think what we end up doing a lot is we give them high flow oxygen. We're not not really sure exactly what they're on because I don't know that 60-liter flow with 50% is different than 40%, 70-liter flow. So we can't tell. And then when the patient fatigues, then we'll try and BiPAP a lot of times. And then I feel like patients fail quite a bit in that setting. So I don't know if just, again, if we took selected populations,
right.
if this might be beneficial.
Mm-hmm.
Selective may have been completely healthy prior to pneumonia, or there's nothing completely healthy, but no.
With the hematologic malignancy patients, they compared non-invasive ventilation to intubation. Using non-invasive ventilation earlier, they had better outcomes.
I think there's a caveat there too.
Yeah. No, I think
Because if those patients who failed BiPAP, they tend to be worse.
Yeah.
So it's a very hard thing to balance.
Mm-hmm.
In that, I think a subgroup there, they benefit on the BiPAP because an invasive airway in an immunocompromised patient, they have more complications down the line. But I think the caveat of that study too is the subgroup that was actually failed BiPAP, who didn't do well on BiPAP, they tend to end up with higher complications. And their exclusion are actually super sick patients, patients on pressors and all those stuff, which is a contraindication to BiPAP. So.
Right. We saw the people that got BiPAP as rescue therapy just did terribly in the study too. To add on to that, right?
More delays.
Mm. Yes.
The tidal volume on the BiPAP.
Yeah.
Was that dependent on how much BiPAP you set it as, or was it like the patients are able to pull that volume because their lungs are compliant?
Right. It was set to. So going back to how to set this up with the BiPAP, it was just set to pull. Let's see. I'm gonna go back a little bit more here. All right. So you would start your EPAP, and there's really no set areas. You just started between 2 and 10. That was kind of your oxygenation parameter. But what they did want here was to maintain the tidal volume of 7 to 10 cc's per kilogram. There's no pressure support delta that they had to set, and there's no maximum IPAP to set.
So what do you think about that fact, though, that they set the pressure support to maintain 7 to 10
Exactly.
per kg?
Exactly. Kind of looking at the high tidal volumes, that there definitely is a mortality difference here of anyone who touches a BiPAP, and especially in the subset of people with moderate to severe hypoxemia. So it does seem like there's probably some, ventilator-induced lung injury coming from the BiPAP.
And these weren't patients who were hypercapnic. Who
None of them were.
That gradient.
Right.
So it seems
Right. A lot, yeah.
So if you were designing the study, you'd set it for 6.
I would definitely set it for 6.
So did that predispose the study to having an outcome where non-invasive was worse than high flow?
I think so, especially with the mean tidal volume of 9 cc's. It's way higher than anything we'd ever set an event. No, I missed the question, sir.
I'm just wondering, if they have just done it that way, instead of just putting people on BiPAP to try to
Right. Should there have been any crossover whatsoever? Or should they have just gone right to intubation?
So will this change your practice? That's the question.
I think so. I like using it, not in your patients, sorry. It will not change my practice in your patients. But yeah, I like to think of the OptiFlow usually as a first line for hypoxemia as opposed to BiPAP.
It's not bad, I guess, compared to CPAP.
Mm-hmm.
It's not worse, so
Except for in your patients. Gina?
So I was looking at the appendix just because I was interested
Yeah.
in kind of how this was, some more data points that they had. And what I found is interesting, and you alluded to it a little in regards to infection rate, but a lot of these patients that were on non-invasive ended up getting intubated for septic shock. And it wasn't
Right.
statistically significant, but the patients with high flow, 19% of them developed septic shock versus 34% of the non-invasive group. And then the standard oxygen group was like somewhere in the middle. And that, even though it's not statistically significant, seemed like a pretty
It's a big
considerable
difference, yeah.
15% of patients, developing septic shock. And what, is there anything that they could potentially tease out of the difference in those groups as to why these
Right.
people develop septic shock? Because I don't think we know. I mean, because you could make an inference that maybe high flow has, is better for these patients, or is it just the patients that they had in these groups happen to deteriorate for an outlying factor that we haven't discovered yet?
Right, and that's the question. Is this hygienically better than just pushing
If I'm
everything
taking
down
on
with
and off my
non-invasive?
BiPAP,
Yeah.
and or have it 4 times a day, bringing it on and off, what's happening in that circuit?
Right, right. In terms of mucociliary clearance, that's the thought. There are studies ongoing for outpatient, like domiciliary OptiFlow for bronchiectasis patients to kind of move things a little bit better, keep people more hydrated, which the BiPAP machine just isn't as humidified. So yeah, are we predisposing to more infections here? It's weird that there's no real difference in nosocomial pneumonia that develops after these people get started on their interventions, but yet so many more people get septic shock. I don't have the explanation for that, but
To develop that hemodynamic instability.
right.
Did they give the power for this study?
What's that?
Did they give the power?
Yeah, based on previous studies or observational trials of BiPAP and hypoxic respiratory failure, they found a 60% intubation rate on standard oxygen versus 50 on the BiPAP. So they were looking for about 300 patients to randomize to get an 80% power. They did not find the big difference that they were expecting in the final results based on that.
Yeah, because if it was randomized, you would think the factors that is not known would randomize to.
Yeah.
So I wonder, I agree.
Is it just the lack of
And if
instability?
it's powered, then that should have been taken care of.
Right. So it was, they came up with that number, however, in the end it was underpowered to find the significant difference.
About their comfort, there was a lot of crossover, but they didn't quantify how much.
Right.
Between the BiPAP and Highflow nasal cannula, and there was crossover between all 3 standards, between Highflow.
Right. So there are baseline comfort scores at 1 hour, or at randomization, at 1 hour, and at 6 hours. So I think that because comfort was so highly focused on at the beginning of the trial, and not so much the end, that we're not seeing those differences once people got crossed over multiple times. And then the fact that so many people didn't wear the BiPAP, like we looked at, the interquartile range was 4 to 12 hours on day 1. So many people didn't wear the BiPAP for the 8 hours on calendar day 1 that should have. I think kind of speaks to the comfort also.
Well, and that's another point too. Is even though the peak that you get with high flow is not that significant, although it can be higher, every time they're taking on and off this BiPAP, they're
de-recruiting
these alveoli. And
Yeah.
So are they really effectively treating that, or are we just getting a lot of atelectasis trauma because you're sending over these alveoli and then they're collapsing?
Right.
5 hours later, you decide to send them over again, and then they're collapsing. And
Right.
so is that really useful, or is that actually causing more harm to our patients? I mean, we aren't very, at our institute, we're not taking people on and off BiPAP, they're on BiPAP, they're on BiPAP.
Right.
But that use is kind of interesting.
And I wonder about the BiPAP OptiFlow sort of interaction there. What if they would have designed the trial to just go on high flow oxygen face mask oxygen from the BiPAP? Maybe you'd see more de-recruitment because you're still getting a little bit of PEEP from the OptiFlow theoretically. I wonder if it would have been more significant if they would have not been invited to the actual trial arm here.
Just going back to Dr. Audis' question, if this would change our practice, I don't know, because I don't know if we should be using BiPAP on ARDS patients to begin with.
Exactly.
So if that's a question, and if no, that's not going to change my practice because I'm not using BiPAP on those patients. I think early intubation.
Right.
I think that if it's like a real ARDS, because we call ARDS to be things, but if it's a real ARDS,
Right.
Depending on
But the question is, it kind of makes you think about trialing the OptiFlow first, as we know there is a mortality benefit. And I guess even in an ARD situation, maybe what comes out of this is shying away more from BiPAP, or at least being more conscious about staying away from that sort of positive pressure that we can't control as well as a ventilator.
I think that my takeaway from this article is three things. The first is that I think that in pure hypoxemic respiratory failure, it's perfectly reasonable to put somebody on high-flow nasal cannula to begin with, and then if they fail, not escalating to BiPAP before you intubate. I think that the incidence of intubation is so high that you're probably not benefiting your patient. Who knows? I don't know. I don't put much credence in the fact that there's a difference in incidence of septic shock when it's statistically insignificant. It may just be stuff that, you know, it may be a neat trend, but it may actually wash out if you were actually getting a high enough power. The second thing that I would take away from this is that, you know, are we going to get any benefit from this mode of therapy in a patient who has hypercarbic respiratory failure? And that study is yet to be done. Which may be actually a more interesting question to ask, because there's clear benefit in those people. And then the third question to ask is, what do we do in Krishna's patient population? She accurately pointed out is, you've got a patient who's now immunosuppressed, who's in respiratory failure with not hypercarbic but hypoxic. Are you going to go to BiPAP first because that population clearly benefits, or do you use high-flow nasal cannula in those patients? And that's where I'm struggling with the data from this article.
Right. So the study's ongoing, at least in pulmonary fibrosis, but I wonder about biotrauma with the amount of oxygen that we're pumping into these people with an OptiFlow machine.
Of course.
Thanks.